3, 2, 1 live.
طيب بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. Initially, I would like to say Mubarak to everyone for Ramadan and also Mubarak for the last 10 days, for this very holy 10 days for all of us. Initially, I would like to say still your society, Saudi Society of Nephrology and Transplantation is very committed for promote the education and learning for everyone in the kingdom as well as our neighbors countries, even sometimes in difficult parts or difficult situation like this now situations, we switch to do our education through the webinar, and alhamdulillah it's very succeeded. Sometimes the attendees are above 2,500 to couples of thousands are reaching. This is the third webinars for us in Ramadan, and it is the first part of first webinar or the first part of the webinar about kidney transplantation, and we will have the second part on Monday, inshallah. It gives me a great pleasure to introduce the moderator, who's a huge name actually in kidney transplantation on all over the world. He's the first winner of the prize of the Saudi Society of Nephrology Life Attuation Prize, and also he was the previous director of the Saudi Centers of Organ Transplantation, and also he is the director of ISODB. Dr. Faisal Shaheen, he's well-known names with tons of publication, is above 300 publications. So go ahead, Dr. Faisal, and the mic is yours, and all webinars are yours. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Khalid, and really I appreciate what the Saudi Society is doing, especially in this very difficult days which we have it at the moment with the COVID-19 and the pandemic and all the pressures all over the health sectors everywhere. I appreciate even the board, the Saudi board, the people who work very hard, Dr. Mutwalli and others, which they are really working very hard in order to give us the information, and even in this difficult situation. As you mentioned, my name is Dr. Shaheen. I am currently working as the head of the department in Sulaiman Faqih Hospital, and I am the president of ISODB and co-chairman of task force of WHO about organ donation and transplantation. Today I am very privileged today to have Dr. Ali Hussein, who is the head of the division of nephrology in Columbia University Medical Center, very well known and had a lot of experience in transplantation. And everyone know that the problem with the COVID, it was very hot in different places in the world, especially in also New York. It was too many cases over there, and the experience over there is very huge. So I'm sure that we are going to hear today in two talks he's going to give about. The first one is about outpatient management of kidney transplant recipient during the COVID-19 pandemic, and the second one, impacted of COVID-19 on the transplantation landscape in terms of donor evaluation and safety. I think these two lectures are very important for us because the things are vague. We don't know where we are going and what we are going to do in the future. It is very difficult and tough time for the patient and for us as well to think about evaluate our patient and starting the program again, or go very fast to transplant the patient, or wait a little bit till things are improved. So we are going to hear from Dr. Said. I'm sure that every one of us will be happy to hear you, Dr. Ali, and please, the floor is you. And again, I would like to thank all the participants, which I heard this is a good number. And this means that nephrology a very important section in a medical field. Please, Dr. Said.
Thank you very much for having me. I'm very honored by the opportunity to give this talk, and I hope that sharing our experience, what we're dealing with in New York, can help you manage your patients as well. So I have no financial conflicts of interest to disclose. So basically, I have 3 objectives I'd like to cover in this talk. The first is I'd like you to understand by the end of the talk what the presentation of COVID-19 is in kidney transplant outpatients who developed a viral infection. The second is I'd like you to understand our management strategy and how our outcomes have differed from other centers who reported their outcome strategy, their outpatient management strategy and outcomes. And finally, I'll talk about the program level implications, as well as what we were talking about, how to manage a deceased donor or living donor program in a safe way in the middle of a pandemic. I'll turn off my camera for a second just for internet stability. So basically, as you know, New York has become the epicenter of the pandemic globally. We have more cases than anywhere in the world. And as a result, we've had a lot of interest in how to manage and what the outcomes are for patients who are particularly vulnerable for severe manifestations of the disease. If you look at the panel on your left, from mid-March to early April, there was a pretty classic surge in cases that you would expect in any major pandemic. The number of cases per day quickly rose to its peak in the first week of April, and then began to fall and is still falling. I think something that's interesting is that among our kidney transplant recipients, we didn't see the same pattern of quick rise and quick fall. And rather, in the same period that I've highlighted on the left, which is the peak period in the red box, if you look on the right, that's the cumulative incidence of COVID-19 in our transplant recipients. The rise and fall was much more gradual. We never saw a large peak. We think a lot of this is due to the fact that kidney transplant recipients were already a group that knew that they were highly vulnerable and practiced social distancing throughout the pandemic, even in the early stages before stay-at-home orders or social distancing rules are being enforced in New York City. But that's presented a unique set of challenges. The first is that we were not able to see the full impact right away. We're still seeing the rise in cases now. The second is that it's prolonged the length of the pandemic and flattened the curve such that we're still dealing with an active phase of the pandemic among our kidney transplant recipients. So the biggest question as this pandemic began to rise was, what would we expect in terms of the outcomes and presentation for kidney transplant recipients compared to the general population in New York City? And really, there were 3 contrasting hypotheses right from the beginning. The first, which I think was the most popular, was that COVID-19 would be much more severe in kidney transplant recipients compared to the general population, because they have a high prevalence of comorbidities such as diabetes and hypertension, because they have underlying immunosuppression that would leave them at a higher risk of severe disease. On the other hand, some people thought that since there's some in vitro evidence that drugs like mycophenolate have impaired replication of viruses like SARS or MERS, and that we know that inflammation is what's typically mediating the decompensation in COVID-19, that perhaps recipients would have atypical symptoms, or they might be protected against severe disease due to immunosuppression. And then finally, a small group of people initially, but now a growing number of people, and this is what I'll argue is in fact the case, now believe that transplant recipients probably have multiple factors that cancel each other out and present and have outcomes that are fairly similar to that of the general population, at least in our experience in the United States so far. But I'll take you a little bit through the story of how things evolved for us. So initially, as we saw that peak, and as I showed you, as we had a very slow increase and gradual increase in the number of kidney transplant recipients who had COVID-19, we had to evolve our management strategy for outpatients in real time. In contrast to inpatients in whom the disease was severe and we could really just focus on managing the acute respiratory distress syndrome, in terms of outpatients, we had very little understanding of how the disease might progress and who might be at the highest risk of having complications as outpatients. Since we didn't know exactly from the beginning what to do in terms of ideal management, and there's such little evidence, our number one focus initially was on educating our patients on preventive strategies to reduce their exposure to COVID-19 both at home and in the hospital. A lot of this involved just standard precautions, so things like hand washing, wearing a mask, staying away from sick family members, as we'll talk about later in the talk. But a large part of that, as we'll also talk about later, is that we wanted to reduce their exposure in the hospital. So a large focus of our initial management was reducing any unnecessary clinic visits, unnecessary labs, or infusions to make sure that patients were interacting with our healthcare system as infrequently as possible. Second was, as we start to have more and more cases, we realized that we needed a systematic method of evaluating and managing these cases without bringing them into the hospital. This was based on a couple things. One, we knew that the hospital was exceptionally crowded. As you might have heard, in New York City, we had a huge surge of the need for inpatient beds and ICU beds in particular. And even all of our operating rooms were closed and converted into ICU rooms that housed 3 to 4 patients each. In addition, we knew that everyone who was coming to the clinic would be at risk of exposure to COVID-19 if they did not have it. And anyone who came with COVID-19 would be at risk of infecting staff, physicians, nurses, and other patients. So we aimed to manage as much of this from a virtual and remote status as much as possible. And we did that with the help of some fever and COVID clinics I'll talk about shortly. And we found that that management strategy was actually quite effective. So first, I want to go into a little bit of detail just about our protocol in case any of you guys would like to utilize it for your own clinics. And then I'll talk in more detail about our outcomes. So our remote daily check-in was the mainstay of our management. In this structure, each patient who called to report COVID-19 symptoms or called to report a positive COVID-19 test received a call by one of our nurses or nurse practitioners every 6 hours, every 24 hours, every 72 hours, depending on the severity of symptoms. In our center, which performs about 200 kidney transplants per year, this amounted to more than 40 calls per day during the height of the pandemic. The purpose of these calls was to establish 3 things. The first was a general symptom check-in, in which we'd want to get detailed information about which symptoms the patients were experiencing and the progression of those symptoms over time. The second was self-monitored temperature, since many people had suggested that persistence or high fevers might be a sign of a high risk of decompensation. And the third was for patients who were able to obtain pulse oximeters, which became very difficult later in the pandemic. We wanted serial pulse oximetry because we could use that as a surrogate of impending decompensation. The advantage of this strategy, as I said, was to allow remote monitoring to prevent in-person visits as much as possible, but also allowed us, as I'll talk about shortly, to triage which patients needed to come directly to the emergency department or to our fever clinic, which was a clinic set up by the internal medicine department for further evaluation. And by doing this in a systematic way, we were able to do real-time quality assessment and quality improvement and change our protocol in terms of threshold for admission and immunosuppression management very quickly over time, because we knew the same data was being collected on every patient. So this is a little detailed, but again, I wanted to include it in case anyone wanted to use this information for themselves. But this is the entire structure of the history of our phone visits. And this is what would happen during every visit with every patient, no matter who was making the call. During the first visit, we confirmed all of the patient demographics and inserted them in a database. So this included their time from transplantation, their age, their sex, as well as major comorbidities that were shown in Chinese data and Italian data to be associated with a higher likelihood of severe disease. After that, the first visit and every subsequent visit had the following aspects. First, we confirmed what their COVID testing history was, especially since many patients were getting multiple tests if they had a first negative test. We logged the date and the result of every test, again, in real time, so that we could see what proportion of patients had serial negative tests that eventually turned positive. And we found this way that some patients even required up to 4 tests in which the first 3 were negative and the 4th finally had positive testing, probably due to aspects of the test itself, as well as the performance of the test by inexperienced technicians. The second is we kept a detailed log of their sick contacts at home or at places like work to make sure we understood where our patients were being exposed to COVID-19. And then finally, as I said, we went through a detailed list of symptoms, and for every patient asked every symptom along with the date of onset and date of resolution, worsening or even slight improvement of each of those symptoms in order to get a better understanding of how the symptoms progressed over time. Finally, in the same database, we collected a lot of information about the overall plan, again, in a systematic way to allow real-time quality assessment. We included all COVID-19 treatment, which is something that helped us eventually make decisions to abandon treatments like hydroxychloroquine or zithromycin. We kept track of their quarantine status to let ourselves know when they could be safely brought to clinic. We had a list of potential immunosuppression changes, which I'll go into more detail shortly, that we kept track of over time. And then the follow-up plan to let us know how many of our patients were being referred to the ER or to fever clinics, what proportion of our patients needed frequent monitoring, so every 6 hours every day versus being able to be spaced out to every 2-3 days or 1 week even, or who could finally stop being followed because they had complete resolution of their symptoms. So this plan really evolved over time. And I think the biggest aspect of the management that we could see our change respond to our experience in real time was the management of patients' immunosuppression. So as you know, many transplant professionals around the world really advocated for aggressive immunosuppression reduction strategy early in the phase of the pandemic, with the understanding that our patients might be at a very high risk of decompensation to severe disease, and that we didn't really understand well enough which patients might be safe to continue immunosuppression. However, pretty quickly, we saw that many patients were able to tolerate pretty conservative reductions in immunosuppression, and some who providers had felt were at high risk for immunologic complications of reduced immunosuppression actually tolerated this maintenance of immunosuppression pretty well. So currently, our our program level decision around immunosuppression management has been left to a provider level decision with the following guidelines based on illness severity and immunologic risk. So for patients who have moderate disease, who are not patients, primarily these patients are ones who will later be admitted, or patients who have severe enough disease to be admitted, we hold their antimetabolites, so their mycophenolates, their CellCept, their azathioprine, if they're on any of those. However, we do not routinely stop tacrolimus or even change the tacrolimus goal trough in any of these patients. Further, on patients who are on prednisone, we typically have not been making changes to those who are on low dose prednisone, and only those who are on higher dose of prednisone for recent rejection or other reasons, we may reduce their dose. So really just holding the antimetabolite has been the mainstay of our management. In those who have mild disease and who have a low immunologic risk as outpatients, we still may hold or reduce their antimetabolite to 50% of their prescribed dose, at least until their symptoms seem to be improving. However, we found it to be generally safe, as I'll talk about shortly in more detail, that patients who have asymptomatic illness or very mild illness with no lung symptoms and who have high immunologic risk, so those who have had recurrent rejections or highly sensitized, we've often been able to not make any change in their immunosuppression as outpatients and still have good outcomes. So overall, among our first 3 weeks of the pandemic, which was kind of the first almost a third of the patients, at this point we've seen over 100 patients with kidney transplants who've had COVID-19. So the first third of those only 63% had any immunosuppression reduction. And these were majority outpatients. And of those, 50% of those, 50% of those who had their entire management at home without ever requiring admission actually were fine with not having any immunosuppression reduction at all. So really, we think that it's a myth that every single patient who has COVID-19 needs to have reduced immunosuppression. And many of those who have very, very mild illness or asymptomatic illness, it may not be worth the risk of reducing their immunosuppression. This in contrast to what you can see on the right. So on the right was a study, was a survey of all US transplant centers performed recently by the Johns Hopkins groups, in which they asked centers what their protocol was for changes in immunosuppression for solid organ transplant recipients who developed COVID-19. As you can see, among kidney recipients, which is the group all the way to the leftmost column, again, the mainstay was primarily stopping or reducing antimetabolites. This was done by the vast majority of centers. And a significant minority of centers would reduce or stop the calcineurin inhibitor. So I think overall management strategies seem to be evolving to those similar to ours, where the antimetabolite can be stopped, but the calcineurin inhibitor can be left more or less the same in many cases. Of course, we've had some patients who've had very severe illness, refractory ARDS or refractory shock, and those patients are ones that we do kind of make more aggressive changes like holding a calcineurin inhibitor and replacing it with steroids, but really this is a small minority of patients. This is again in contrast to international experience that's been reported of patients who, importantly, when you read these reports, are almost entirely inpatients. So that a Callan study that you might have seen in the New England Journal of Medicine a few weeks ago, that was in Montefiore Medical Center in the Bronx. They almost all patients, they withdrew the antimetabolite and held tacrolimus in 1/5 the patients. In the Alberici study from Brescia, Italy, every patient with COVID-19 had their entire transplant immunosuppression withdrawn and replaced with 16 milligrams per day of methylprednisolone. And then in our own study of inpatients, which Marcus Pereira will talk about on Monday, we had almost everyone had their antimetabolite discontinued, and many had other immunosuppression changes at all. But again, the important thing to remember about all of these reports, and that one from Wuhan and Spain in the bottom, in almost all of the patients were inpatients. And you can see there in the top right corner, the exception is that in the Callan study from Montefiore, 2 out of the 8 patients, or 25% of those who were being monitored as outpatients, died as outpatients. And we'll talk about how that's very different from our experience at Columbia. So the second big question was, when should patients be admitted for doing this aggressive outpatient monitoring protocol? This is a set of guidelines that were published by the group at Yale Medical Center in New Haven, Connecticut, in the United States. So based on their guidelines, they primarily based the decision to refer for potential admission and hospitalization on a few things. In terms of symptoms, this was based on persistent or worsening dyspnea, severe or refractory vomiting or diarrhea that might make it difficult to maintain hydration status or to take medications as prescribed, confusion or mental status changes that might indicate worsening hypotension or shock or overall severity of disease, persistent hypoxemia, persistent fever, or any clinical gestalt that the patient might be decompensating at home. Interestingly, they also had a set of guidelines based on laboratory or imaging findings, including AKI, transaminitis, high CRP, or abnormal chest X-ray. But as we talked about, for us, most of our patients were staying home, and either due to illness or due to concern for exposure to themselves or others if they left home, the vast majority had no laboratory testing and no imaging performed unless they were eventually referred to the ER or to the fever clinic. So this was really, this second part in terms of lab findings, imaging findings, was not part of our management protocol. So with our more conservative strategy, which I would like to argue to you, provided as good or better outcomes as has been published elsewhere, we were fairly happy with the results because we had better outcomes overall than had been reported by the group at Montefiore. So in the first 3 weeks of the pandemic in New York City that I showed you that graph for earlier of the histogram, we had just over 40 kidney transplant recipients with known or suspected COVID-19. Of these, only 20% who did not end up hospitalized required an in-person evaluation, and the rest were able to stay home, which was an important thing, as we'll talk about in terms of resource utilization for our center. Of these first 3 weeks of cases, only 1/3 required hospitalization eventually, and the rest were managed entirely at home. For those who eventually required hospitalization, the median time from symptom onset to the day of admission was 8 days, which is very important to note, especially because the range was actually quite wide. So one patient was admitted only 1 day after symptom onset, and one patient was admitted as late as 16 days after the first onset of symptoms due to worsening respiratory status. Overall, this median is similar to what's been reported by the CDC for the general population of the United States, in which the median time to admission was 7 days with an interquartile range of 3 days to 9 days. But again, that long tail of 16 days is something that makes us emphasize that patients must be followed until symptomatic resolution, especially if they're having respiratory symptoms. For the remaining 2/3 of patients who were managed as outpatients only, the median time from symptom onset to resolution of symptoms was 12 days. But again, the range was very wide, with some patients taking only 4 days to have symptom resolution, but some patients taking as long as 23 days. And again, given that we knew this long tail existed from symptom onset to admission of up to 16 days, this required maintenance of our aggressive outpatient monitoring protocol throughout the entire course of symptom presentation to resolution. Importantly, with our strategy of outpatient management, despite being more conservative about using hospital resources and despite being more aggressive about keeping patients home compared to the group at Montefiore and other groups that have reported their outcomes, we had no deaths as outpatients. Although we did have some patients who eventually were admitted to the hospital and died as hospitalized patients, no one died at home, in contrast to that Callan study. So what were the characteristics of these patients in terms of who was getting COVID-19? So in these first 3 weeks, which is what I'll focus on because it's what we had the most robust data on, about 3/4 were male, which is interesting because there also seems to be other data internationally that suggests that men might be at a higher risk of developing, especially more symptomatic disease. The median age was 49 years, although there was quite a large range. And the median time from transplant was actually about 3.5 years. And the 25% of patients were less than 1.5 years out from transplant, but 25% were more than 5.5 years out from transplant. And there was not any association between time from transplant and likelihood of needing admission for those who presented first as outpatients. There was a very high prevalence of hypertension among our patients, as is common among many patients with kidney disease, which was important for us to know because we knew that this was a risk factor for severe disease in Wuhan in Italy. There was a high prevalence of diabetes in greater than 1/4 of our patients, and more than 3/4 of our patients had overweight or obesity, which is another risk factor for severe disease. However, none of these factors were different between patients who stayed at home and those who were eventually hospitalized. Additionally, the use of ACE inhibitors or ARBs was low overall, so we're not really able to comment on whether these were different between groups that had different disease severity. But we are able to tell you that although the median baseline creatinine prior to development of illness was only 1.5, there was a significant difference among those who were able to stay home and those who were hospitalized. And those who were hospitalized had a median baseline creatinine of 2.0 compared to 1.3 for those who were able to stay home, which was consistent, again, with data from around the world that has shown that chronic kidney disease is a strong, strong risk factor for the development of severe COVID-19 manifestations. Overall, half of our patients had a sick contact at home before developing symptoms, which is another important fact to remember when we're trying to guide our patients about how they can best avoid these illnesses, especially at times when we know that hospitals are overwhelmed and testing capacity will be overwhelmed, and prevention is the best strategy. Among our initial 3 weeks of patients, there was also no difference in baseline immunosuppression regimen among those who were able to stay home and those who were eventually admitted to the hospital. Overall, more than 3/4 of patients were on calcineurin inhibitors, almost exclusively tacrolimus. More than 2/3 were on mycophenolate, either MMF or mycophenolic acid. Interestingly, about 40% were on prednisone, which I think is interesting primarily because our center is actually a steroid-sparing center. So our standard protocol is to withdraw steroids at 4 days after transplant, and patients who only have maintenance prednisone as part of immunosuppression, they have a history of prior rejection, another sensitizing factor, or have IgA nephropathy. So this was a surprise to us and leads us to believe that there's probably some relationship between prednisone and severe disease that we are not able to tease out yet due to small numbers. Finally, a very small number of patients were on azathioprine or belatacept, the latter of which, of course, leads to challenges that we'll talk about again in a moment. Consistent with what the Yale group recommended, we have had a similar experience that really the symptom that's the harbinger of later decompensation is dyspnea. So patients in our cohort presented with similar kind of characteristics in terms of fever and cough being the most common symptoms of COVID-19, which argues against some people who said that perhaps many of these patients will have very, very weird symptoms. So, the first cases out of Wuhan and Italy suggest that perhaps, sorry, not out of Italy, but out of Wuhan, suggests that perhaps these patients might have atypical presentations. But we really saw fever and cough as the primary symptoms. But those who had dyspnea were 4 times more likely to be admitted than those who stayed at home. Things like GI symptoms, diarrhea and vomiting, myalgia, and malaise were present in a significant minority of patients, but were no different between those who stayed at home and those who were later admitted. this showed a pretty striking similarity to patients, and this is something that Marcus Pereira will talk to you about more on Monday, but a striking similarity of patients who were presented initially to the hospital as inpatients rather than managed as outpatients first, in which fever again was a predominant symptom and cough was again the predominant symptom. Although it's important to note that there's a big limitation in terms of who's tested and who's not tested. And we know that in terms of when we look at the last slide about our outpatients, many patients who had mild disease, who were developing illness early in the New York pandemic when there's very, very limited availability of testing, might have fallen under our radar. And this might be an overrepresentation of some of the more severe symptoms that presented in these patients. So in summary, for this first part of our talk, it's important to know just that kidney transplant recipients with COVID-19 at our center presented very similarly to the general population. The vast majority were able to stay home with a remote monitoring protocol and a fairly conservative protocol in terms of immunosuppression management that allowed many of them, over half, to stay on their baseline immunosuppression without a high risk of needing admission and with no outpatient deaths. And finally, that the biggest risk factors for need for hospitalization among these outpatients were dyspnea and higher baseline creatinine. Some challenges to this outpatient management strategy that we experienced are outlined here. So the biggest thing, like I just mentioned, is the limitation of testing that we think biases our understanding towards more severe cases. Early, we couldn't test anyone, basically, at the beginning who was an outpatient with mild disease. And we knew that there's substantial risk to bringing them into the ER for testing because their ER was basically full of COVID. As a result, patients with mild disease might never even come onto our into our atmosphere and not be included in our cohort. The second, like I mentioned earlier, in comparison to the Yale group, that there's a big lack of availability of labs and outpatient imaging for the reasons I mentioned. An important limitation that relates to that is that we're unable to include this data, which is probably very valuable, into our risk stratification algorithm. But overall, we felt that bringing patients out of the home was simply not worth the risk when so many of them were doing well at home. And finally, the biggest question in terms of managing these patients as outpatients and eventually bringing them back to our clinic is when can they return safely to our clinic and not risk infecting our nurses, our technicians, our physicians, and the other patients who are there, especially because many of these patients, needed some evaluation before we made changes to their immunosuppression if they'd previously been reduced. An important factor in this is the increasing number of cases reported that patients can have prolonged viral shedding potentially after the development of COVID-19. So in the bottom left figure, you can see a case report from China that discussed the serial antibody testing and RNA testing for a kidney transplant recipient who had developed COVID-19. As you can see in the line with the orange crosses, the patient initially had a positive SARS-CoV-2 RNA testing on day 10 after symptom onset. And even after having negative testing, as their immunosuppression was reduced, as late as 57 and 63 days after their onset of symptoms, and even after symptom improvement, to the point where they were able to return to full dose tacrolimus, they still had 2 positive SARS-CoV-2 RNA tests. And of course, we don't know whether this is residual viral particles that perhaps are not infectious or not, but in a setting where many of the patients that they will interact with in the elevator, in the waiting room, I mean, the providers that they will interact with are vulnerable to disease, it provides a challenge in terms of saying, how could these patients be brought back to our clinic? And then you can see there on the rightmost figure that on this slide, there have been primarily the guidelines that have been issued have been for larger groups like hemodialysis patients, who we might consider to be somewhat similar to our group because of underlying immunosuppression. And these have been things related to guidelines related to factors like their symptoms have resolved for more than 7 days. They've been past at least 10 days since onset of their symptoms. They've had repeat negative swabs. That seems to make sense based on data from the CDC about when patients can transmit viable virus. But again, since this has not been robustly studied in kidney transplant recipients, it makes us nervous. And so our practice has been that for patients who need to be seen who have COVID-19, we have now dedicated a single day at our transplant center in which all solid organ transplant recipients who have COVID-19 can be seen. So we do this on Fridays. That way, at the end of the day on Thursday, the clinic can be sterilized. On Friday, these patients can be seen with aggressive kind of precautions and aggressive cleaning. And then after that day on Fridays, the whole center can be cleaned again before our standard patients return to the clinic on Monday. So I'll move on to a little bit about how this, the second half of the talk, which is how this impacted our program and our transplant landscape as a whole in New York and the United States. And then I'll leave about 15 minutes at the end for questions. So one big part before I move on to the transplant landscape itself was the impact of post-transplant care on patients who did not have COVID-19. As you can imagine, there was a big surge of cases that kind of took over our care priorities. And as I said earlier, one large strategy for prevention was preventing unnecessary visits to our clinic among patients who are asymptomatic. As a result, we transitioned to primarily telehealth visits for any patient who had a non-essential visit. This was able to be accomplished because our electronic medical record system, which is we use Epic, had an integrated platform for visits. And at our peak, we've been doing more than 40 telehealth visits per week as a center. In addition, we had a large volume of calls for patients who, many of whom were nervous and had questions that are simple, like, how can I prevent the virus? I have a family member who's sick. How should I quarantine myself from them? My work is asking me to return to work. How can I respond to their request? As this large call volume increased, we had to overhaul our care post-transplant care model to include additional staffing. So you can see that on the right. Typically, our model was that we have every physician, transplant physician, is associated with one transplant coordinator who's a nurse practitioner and one administrator. So for example, I have my one designated nurse practitioner, one designated administrator, and the three of us work together as a team to take care of all of my patients. As many physicians were redeployed, and as the volume of calls really just exploded, we realized that and many of our nurse practitioners were redeployed as well, we realized we had to condense our efforts. So by the end, we had multiple physicians working with a single NP and a single just regular nurse and a single administrator to pool our resources to allow more give and take between patient pools. And the way we were able to achieve this was by taking the nurses from our pre-transplant and living donor programs to help us out, since those programs, as I'll talk about, got put on hold. Another part of this was maintaining social distancing in our clinic, because patients without COVID-19, we still wanted them to keep, at least 6 feet of distance. We wanted not to overcrowd our waiting rooms. So we had to decrease our clinic volume overall and decrease our infusion suite and lab and biopsy suite volumes to make sure that we can maintain these social distancing rules. But even with that, many patients were highly reluctant to come into our clinic. They were patients who needed things like as simple as, or as essential as belatacept or kidney biopsies, or things like IVIG or cidofovir. And they were very reluctant on potential exposure in our clinic. So part of our post-transplant care changes had to be developing a system that left them confident that we were taking care of them and being able to move to home lab draws and home infusions wherever feasible. But for us, at least in our insurance landscape, this often took as many as 6 weeks to set up for home infusion. So I would encourage you, if you're still seeing a lot of cases, to work aggressively from the beginning of your peak to make sure that you have all these things set up so when you need them, you can use them readily. Finally, many of our staff were redeployed. So for our medical center, which is the largest medical center in New York City, we had a 300% increase in general nephrology consult volume. And 30% of our patients who ended up in the ICU with COVID-19 needed renal replacement therapy due to acute kidney injury. All of our transplant nephrologists are obviously trained nephrologists. And so we were pulled away to assist with these efforts because we were, our division was just overwhelmed with the number of consults we had to provide. So our care model had to take this into account as well. And really, we relied heavily on our nurses and our nurse practitioners and even our administrators more than ever before. And they really were able to help us mostly because, again, we set up everything systematically so we could monitor in real time to see where our deficits were. So the impact on our kidney transplant program was pretty abrupt. So starting with our living donor program, this was shut down quickly as soon as the pandemic began to pick up in mid-March, and is still on hold now. So you guys might be familiar with Peter Rees, who's a famous kidney transplant epidemiologist from the University of Pennsylvania. And he had posed a few questions to the transplant community online, on social media, about kind of the ethics of living kidney donation in the middle of a pandemic, with a focus on two main factors. One is that continuing living donor transplants would expose a living donor to the risk of COVID-19 by bringing them into the hospital system. And we knew that many healthy patients were still developing severe disease. So we thought that this was probably unethical. The second is that we had massive shortages of things like gowns, gloves, and masks, and even our operating rooms were being converted into ICU rooms. So we thought it did not make sense to invest healthcare resources in performing these surgeries that could wait just a few months until the pandemic had abated. Further, we knew that there was limited testing capacity for donors, and that there are also window periods in which donors might be able to transmit the virus, but we might not be able to pick it up. And we thought there was an unnecessary risk to living donor recipients who, again, could easily just wait a couple of months until they get their transplant. The deceased donor program was a harder decision, although it was also dramatically reduced and from all intents and purposes, pretty much on pause starting in mid-March, although we've now recently begun to open ourselves back up to a higher volume. The rationale was the same. We knew that it might expose recipients to COVID-19 by interacting with the healthcare systems, and it might also use a lot of healthcare resources that would otherwise be needed for COVID-19 patients. But unlike living donors, deceased donor recipients didn't have this transplant waiting for them to easily take advantage of after the pandemic was over. And for many of them, the question was, what if this was their one transplant? What if this was their one chance for a transplant? This was particularly true for patients who were highly sensitized, so those who had a panel-reactive antibody greater than 99%, or those who had exhausted their dialysis access. So you must have these patients as well, those who have failed fistulas, failed graft, have failed their internal jugular tunnel dialysis catheters, and are on last chance access, things like transhepatic catheters. For these cases, we maintained our deceased donor program as active throughout the pandemic because we knew they might not have another chance for transplant. In order to safely do this, our organ procurement organization called Live On New York had an aggressive protocol of testing all consented donors for COVID-19, regardless of whether or not they had symptoms. Of course, this raised its own set of questions. You might have seen that report from the OBGYN department of Columbia University that showed that perhaps as many as 40% or more of patients with COVID-19 might have false negative testing. So in light of that, we still proceeded under the assumption that there's always a chance that no matter how many negative tests a donor might have, they potentially could have COVID-19. And really, we treated this same attitude throughout all of our hospital care, both in terms of the pre and post-transplant environments, because we knew that patients are contagious before they develop symptoms, and that testing is often a false negative. So we tend to treat all of our patients with aggressive precautions as if any of them could have COVID-19. In the meantime, since our program was not doing many transplants, as I mentioned, we redeployed many of our nurses to help in other aspects of care, and also made a big push to keep our evaluations moving. So things like cardiac testing, living donor stress tests and stuff obviously couldn't be done because we didn't want to bring people into the hospital, but telehealth visits and other remote testing that could be done for potential donors or potential recipients, we tried to accomplish just so that our program could hit the ground running once transplants picked back up. And finally, as I said earlier, our physicians were redeployed, and this included our surgeons. So many of our surgeons got redeployed doing things like doing procedures in the hospital or being attendings in the ICU. And even some of our transplant nephrologists who were not doing nephrology were redeployed as ICU physicians because of our expertise in acid-base and fluid and electrolyte. So for all these reasons, it made sense to pause our programs. But like I said, now as the pandemic is starting to abate, this calculus continues to change because we know that longer time on dialysis is associated with higher mortality, both before and after transplant. So the goal is to restart the transplant program as quickly and as we can do it safely. From a national level, this has had a big impact on organ procurement and allocation. So you might have seen this paper from the Lancet last week. This was a group in France and Peter Reese's group in UPenn combined to examine organ allocation and organ recovery practices in both countries. As you can see here on the left panel, the red line is the number of COVID-19 cases in both countries over time. And this is from early February to early April. And as COVID-19 increased in incidence and prevalence, organ transplants as a whole dramatically reduced over time. So this is on the blue line, this is number of transplants per day for each day, dropping to less than 3 transplants per day. If you look at the right panel, you can see that this was entirely driven by a reduction in kidney transplant volume. And in many parts of the country, kidney transplant volume dropped to pretty much 0 transplants per day because many programs felt that unlike heart or liver recipients or lung recipients, our patients might be better served by potentially waiting a few days or a few weeks rather than taking the risk of induction immunosuppression during the height of the pandemic. Fortunately, this is starting to change in America. As our testing capacity increases more and more, and we feel like we can do this safely, and as the number of new cases in major metropolitan areas such as New York begins to decrease, we've seen it start to shift towards normal. So that, like you'll remember that graph I just showed you just now, we're up to April 3rd. So this is national data up to April 26th for the United States. The number of deceased donor kidneys recovered by week, as you can see here, took a deep fall in early April, consistent with the data I showed you from the Lancet article, but has now recovered to 218 per week, which is almost getting close to the 250 to 270 donors per week before the peak of the pandemic. The volume of deceased donor kidney transplants over time has mimicked this to a T. And as you can see, at our peak, we're doing about 400 transplants per week. We're still only at 300, but clearly above the 200 we're doing at the worst part of the pandemic. Over time, though, these changes have still caused us to lag behind last year's transplant volume, despite early in the year gains that had left us hoping that we could exceed the transplant volume from the previous year. So you can see here, this green line is 2020. And we, until March, had been exceeding our 2019 volume as a country, but have fallen behind and continue to be on a slope to leave us behind last year's numbers. This has primarily been driven by a decrease in living donor transplants, but deceased donor transplants have also come back to last year's data. To be honest, I wish I could give you a good answer on what the best way to test and triage donors are to do this safely for deceased donor kidney transplants. Unfortunately, there is no robust evidence about COVID-19 seropositivity among donors, or especially COVID-19 false negative testing or repeat test results among potential deceased donor kidney donors. So I think that the problem is, at least at the beginning of this reopening phase, we'll somewhat be flying by the seat of our pants, and there is some risk that we will have to mitigate by, again, performing very systematic data capture and real-time quality assessment and quality improvement as we see what's happening. Finally, just a quick word about our wait list. Since the majority of our transplants that are done in the country are deceased donor transplants, while the majority of patients on our wait list have remained active, there's been a large minority of patients, up to 10%, who've been inactivated primarily due to COVID-19 precautions. As you can see here on the right, for all new kidney waitlist inactivations over time, the primary new reason for inactivation has been concerns about COVID-19. Some of this is driven, or I'd say seems to be majority driven by centers, but as we establish that it's safe to resume transplants, I think an important thing to do will be convincing our patients that we are taking adequate safeguards to protect them during the transplant process. Because some data that I've not shown here, but data that will recently come out from our group in the Journal of the American Society of Nephrology has shown that mortality for COVID-19 among dialysis patients is even higher than we have found for kidney transplant recipients. And greater than 30% of our ESRD dialysis patients who have dealt with COVID-19 have died in the hospital. So we do not want patients staying on on dialysis for years, waiting for the entire pandemic to die out, because at some point there might be a greater risk of them staying on dialysis, being in a dialysis center where they're going to be exposed to other people, and developing severe disease of COVID-19 when they could have been safely being transplanted. So as a last slide, I'll just discuss some remaining questions, in addition to what I just mentioned about questions about how to safely resume transplants. As I said, we still don't totally know what the optimal immunosuppression management strategy is for these patients. Our belief, based on our data, is that many patients can have a modest reduction. But like I said, other centers have taken other approaches. And I think what's really needed is a national and international COVID-19 transplant registry, so we can really answer the question that among a diverse group of management strategies and a diverse group of transplant patients, what is the optimal immunosuppression management strategy? The second question is, what is the ideal strategy for management of acute kidney injury in these patients? An increasing number of reports have shown that COVID-19 can directly affect the kidney. And studies from multiple investigators have shown viral particles directly in kidney parenchyma. On the right, I've shown you two studies. So the leftmost one, the preprint from China, had suggested that there's a large burden of inflammatory cells in post-mortem analysis of patients who died of COVID-19. In addition to CD68, CD8, and CD56 positivity, they also had complement activation that they had found in the kidney pathology autopsy specimens of patients who died of COVID-19. In contrast, other data from China that was published in Kidney International suggested that the primary finding for these patients who died of COVID-19, even those who had AKI, was acute tubular injury, and that inflammation was not as big of a factor. Although they did note upregulation of ACE2, as you can see in the top right corner, into the glomeruli, et cetera, and viral staining, positive viral staining for viral particles in the kidney itself. As you know, ACE2 is obviously present in the renal parenchyma, renal epithelial as well, just like it's present in the lung epithelium. So it's reasonable to suspect that direct viral infection is one mechanism of injury. However, other causes of AKI could easily be present in our kidney transplant patients who develop AKI. These include things like rejection, or urinary tract infection, or thrombotic microangiopathy from things like calcineurin inhibitors, or recurrence of native glomerulonephritis. Our strategy so far has been to do a pretty conservative workup for AKI for patients with COVID-19. So even though it differs from provider to provider, what I typically do is obtain a renal allograft ultrasound with Doppler just to make sure there's no anatomic problem that needs quick intervention. And I obtain a urine culture to make sure it's not pyelonephritis. Other than that, I do not perform a kidney transplant biopsy when they have active COVID-19, with the assumption that there's a high chance that they might have COVID-19 related disease, either ATN or some other fact that we don't understand well, and that it's highly unlikely that we would immunosuppress them for rejection while they have active COVID-19. And instead, what I do is I wait until they have COVID-19 resolution before reassessing their kidney function and deciding about a biopsy. The impact of these decisions about AKI management and optimal immunosuppression management obviously leads to its own set of questions about what the impact of this will be on allograft function. If there's inflammation in the kidney being brought on by SARS-CoV-2 infiltration, and we are decreasing based on immunosuppression, of course there's a risk of precipitating a rejection, as there isn't any other infectious process. We have had one patient that I know of at least who had an acute cellular rejection, a 2A rejection, at the same time he had a new diagnosis of COVID-19. The management of this patient and others like it will be challenging because we are very reluctant to immunosuppress them. In that patient, our strategy was to first try increasing calcineurin inhibitor doses with the thought that that might help manage rejection and initial treatment with tocilizumab. And then after he did not respond and he did not display any significant symptoms of COVID-19 and a repeat biopsy showed ongoing aggressive rejection, he was eventually treated with thymoglobulin and steroids with a good outcome. Finally, managing asymptomatic patients, as I mentioned earlier, continues to be a question, both in terms of understanding whether these are true positive cases, who undergo testing in the community just because they want to know whether or not they have COVID-19, and in terms of the management of immunosuppression. And then apart from clinical management, a big question has been to us, how will we manage these patients who don't have COVID-19 and who don't have a history of infection as our city reopens? So we expect within a couple of weeks that New York City will begin its first phase of reopening, potentially as early as May 28th. Many of our patients who are employed or who otherwise need to get around the city, we don't really know how to best mitigate their risk of returning to regular life, especially because their employers might not permit them to continue to stay home if their place of employment reopens. These are questions I think we'll need to answer with time. And again, I think if you can take one thing out of these two talks that I've given, the biggest thing you can do is have robust and systematic data capture, so that in real time, any members of your team can answer the questions that come up. Our data that we're collecting is available to any of our nephrologists or surgeons with just a click of a button, and it requires basically anyone who requires analytic help has help from myself and other people who are statistically trained to make sure that as questions arise, we can answer them quickly, and our data structure really supports that. So that is the end of my talk, although I'm happy to stay on as long as needed to answer questions. Thank you very, very much for hosting me. I really am honored by the invitation.
Thank you very much, Dr. Ali, for this excellent talk and overview about how we manage transplantations in this era of COVID-19. And actually, we bring everything probably we thought about the patient preparation, transplantation, how we can manage the patient even at home, how we can follow them, and even you touch a lot of about immunosuppression, what immunosuppression we should use, and when we reduct or not. And I will, if you don't mind, I will take the chance to have the first question from myself, that we are in a group internationally thinking about COVID in the future with the organ transplantation. And this from Canada, United States, and from people in Europe. And we think that probably when it is this lockdown, it open and start to open, that we should probably consider the COVID positive donor as the same like HIV donor, which been accepted in the United States. So is this the same thought which you have it in New York now? This is my first thing. The second, probably again the same about the zero negative and zero positive. Which one we should choose? Negative to positive, positive to negative. Maybe till now we don't know exactly which one we should give, which one not. Can I have your comment about this, please?
Sure. Yeah, those are great questions, and I think these are the hardest questions that we'll have to answer as we resume our transplant volume back to normal. So to take the first part of the question, I think that I'll take it in two parts. So first with this deceased donors. So I think our general philosophy, and again, some people in the United States might disagree with me because there's not good evidence on this. Our general philosophy is that a deceased donor who has COVID positive testing should be assumed to have transmissible COVID-19 disease and should not be used as a deceased donor. You might have seen a pair of articles in AJT, I think it was about a week ago, one from the Seattle group and one from David Goldberg's group, in which they argued that between them, the Seattle group saying that it was safe to use these donors because the risk of not performing transplants for patients who have end-stage organ failure is greater than the risk of COVID-19, especially since we don't understand what the testing means for deceased donors. I think that while this might be true for patients who are waiting for organs like heart or lung or liver, who will really imminently die if they don't receive a transplant, patients with kidney failure who need a transplant, while we do want to transplant them as soon as possible, it's just not worth the risk of COVID-19, especially because the few cohorts that have shown severe disease among COVID-19 kidney transplant recipients, especially the Montefiore group that published in New England Journal, showed that the highest degree of mortality was among patients who had recently received high-dose immunosuppression like thymoglobulin. So I just don't think it's safe to do induction immunosuppression in a recipient who's receiving a kidney from a donor who's COVID-19 positive. In terms of a living donor, I think the same thought is appropriate, but with the added caveat that once they have achieved viral resolution and they're seropositive for anti-COVID IgG, and they have been not, had serial negative RNA testing over time, it's probably safe to use them as donors. Although again, that's purely based on opinion, and I think it'll be, again, very important to see what happens over time, especially because we know that some groups have prolonged viral shedding. I think ultimately what we'll probably see is that many recipients won't want to have these kidneys kind of transplanted into them for several weeks until the donor is negative for several weeks, which I think is reasonable.
Okay, thank you. I think it's very good and informative answer. There's one question from our colleague Osama, and he said, how is the management plan for the non-COVID patient in the regular clinic, and how frequent you see them, especially with the difficult, with the different transplant duration and graft function? That's
a great question. And that was the first decision we had to make as we changed our program in response to the pandemic. So I'll tell you a little bit about our typical protocol. So typically, in a patient who has a new kidney transplant, we'll see them twice a week in the clinic, once for labs alone and once for a physician visit for the first 3 months almost, for every twice a week to once a week for the first 3 months. And then for patients who have graft dysfunction, we see them pretty commonly too, as often as 2 to 3 times per month. Once the COVID pandemic began, we totally changed this. And we said that we should only see a patient in clinic who has to be seen in person for a decision to be made. So from a practical perspective, for new kidney transplants, this meant really reducing their in-person visits to as infrequently as every 2 to 3 weeks if they were stable. And for patients with graft dysfunction, to moving to primarily telehealth visits, again, with visits spaced out to every 2 to 3 weeks or even longer. And the idea being that many of our patients are savvy enough to measure their weight at home and to give us a pretty robust symptom reports, to measure their blood pressure and other signs of allograft dysfunction. And we could arrange lab tests either at their home, because we partnered with a company to do home lab draws, or at labs close to their home to prevent them having to travel to the hospital. So basically, I know it's not a strict answer of how frequently exactly, but our protocol has been to see patients in person as infrequently as you can possibly allow yourself to tolerate. And many of us have said that we were managing things at home that we never managed at home before, even things like UTI and early fever and shortness of breath and edema. But I think these things are important to manage at home whenever possible, just because of the risk of bringing patients into the hospital, especially because our city primarily relies on public transportation, which you might have the same problem with. We definitely don't want our patients getting on buses and trains.
Oh, thank you. Actually, the same, which we have it in Saudi, we have virtual and phone conversation with our patient, and we dispatch medication to home, and even we send some people to take collect blood from home.
That's
so
great.
Home service is maybe the ideal in this pandemic situation. There is one question about sirolimus, and did you have any experience for people who had sirolimus? Should we keep the same dose, change the dose, or?
Right. So we have not actually, surprisingly, in our first set of data that's been analyzed, we have not had any patients on any mTOR inhibitor, so not sirolimus or everolimus. So our plan had been that if they're on sirolimus and a antimetabolite would be to leave the mTOR inhibitor the same and hold their antimetabolite. But to be honest with you, I can't speak from experience because we just don't know if this would be an effective strategy or not, just because we didn't have it in our early group. You know, some people have always said that mTOR inhibitors might have antiviral properties. So you know that many people like to believe that this is a good strategy for things like BK viremia. I think that there's no strong evidence, no strong evidence for that in the first place, although many of us, including myself, will often do it for refractory cases. But there's certainly no evidence that that these mTOR inhibitors have antiviral effects against coronaviruses, you know, things like SARS, MERS, SARS-CoV-2. So there's no reason to increase it in these patients. I'd say just based on our opinion, probably I would keep it the same. But again, we don't have data to support that yet.
I think this will answer the next question, which comes from one of our colleagues, that to change CNI to MMF or M2. This you answered these questions already.
Right. So basically exactly what I said. So we do not, in fact, the CNI is a thing that we have changed the least so far. So the majority of our patients have immunosuppression reduction. We leave their CNI the same, with the idea being that we know that they're going to be at increased risk of rejection. And what we don't want is for them to get COVID-19 and rejected at the same time, because that will be impossible to manage.
Yes. Another question is about using IVIG for those patients. Do you have any experience or any protocol for that?
So we have not used IVIG for any outpatients. However, we've used it routinely for inpatients. So this will be part of the talk that Marcus Pereira gives you on Monday in terms of antiviral therapy for patients who have moderate and severe disease in New York. But what I'll tell you just briefly is that it's hard because there's a big selection bias in who we're using IVIG on, which is more severe cases. But we have used IVIG routinely in patients with severe cases. And Marcus, like I said, on Monday, will tell you more about what he thinks the impact of this has been on our patients.
Okay, another question, which again asking about how many percentage of your patients develop pulmonary problem, either they need ventilations or they have some sort of pneumonia which require ventilations. How many of those patients, of your patients?
Sure. So that's a difficult question to answer, but I will give you an answer. But I'll just say the difficulty in answering that question is just because we know that there's a heavy bias towards identifying more severe cases of disease and to identifying specifically cases of COVID-19 who have respiratory symptoms, because there's a big limitation for testing initially. So all of these are probably overestimates. Okay. But in our early data, so just in terms of SARS-CoV-2 pneumonia in general, in our early data, about a third of patients had no evidence of pneumonia on their among those who got admitted, had no evidence of pneumonia at all on their initial chest X-ray. So we can believe at least some of those patients, or the majority of those patients, of 1/3, might not have any pulmonary involvement at all. I'm going to share my screen again for a second just to show you a different slide. Sorry.
Okay.
My apologies. Here. So I'll show you that around the globe, there's been really varying reports of who's required intubation. So this line, us here, is our early report that was published in JASN. But in our early report, about a quarter of patients required intubation. And 2 of those patients eventually died.
Okay.
Sorry, one of those patients eventually died and during the course of the report, and 1 later died. So it's not published in our cohort. But just so you know, 1 patient died. If you look at other cohorts around the country, so the Montefiore Medical Center in New York City in the Bronx, 7 out of their 36 patients required intubation. So again, somewhere around 20 to 25% probably. This was again similar to what you saw in the Alberici study from Brescia, and then other smaller case reports. I think that the proportion was just too small to say. So maybe if we say 2 out of 8 here, we might say 25% as well. But again, this number is so small that it's hard to tell. So I would say we just don't know the answer overall, but probably somewhere around 20-25% of admitted patients, which is the exact same as what we've seen in Columbia University Medical Center overall. So probably similar to overall population.
Okay, probably the same question. Many people are interested in immunosuppression management post-transplantation and how to manipulate either to increase or decrease, asking about steroid therapy. Most of the people don't like to increase the steroid. What's your opinion about doubling the dose of steroid in these conditions?
Yeah, so this is something that's gone, so our protocol has changed person to person throughout the course of the pandemic. So early on, during the first wave of the pandemic, I was attending on the kidney transplant service. And so at that point, the data around steroids had shown that steroids probably did not provide a benefit for COVID-19 and probably only increased the duration of viral shedding. So my initial practice was to reduce the steroids if it was greater than 5 milligrams to 5 milligrams per day, and to only increase the steroid dose if we were reducing the rest of the immunosuppression to a dramatic amount. So for example, there was one patient who we stopped the tacrolimus and mycophenolate on and replaced it with steroids. Similarly, the Brescia study had shown that they eliminated immunosuppression overall and just gave steroids. The thought that it provided adequate immunosuppression and was potentially protective against the development of severe acute respiratory distress syndrome. Our our institutional policies probably changed a little bit. So I think we no longer aggressively reduce steroids. And in patients who have severe acute respiratory distress syndrome, we will often increase the steroid dose for part of treatment of ARDS. However, we have not used increased steroid dose on patients who do not have acute respiratory distress syndrome, and we don't think it has a role in the management unless we're trying to do pulmonary protection for severe pulmonary disease. Okay,
thank you. Actually, we have one interesting question about the vaccination of COVID when it is available. Did you think that we can give it to our transplant patients? This is a very interesting question. Anyhow, we don't have it now.
This is a very, very interesting question. I think it's going to be really dependent on what we see in terms of which is the first wave event of the vaccines, what their mechanism is. Of course, if we end up with a live attenuated virus, my initial instinct would say probably this would not be safe to give to transplant recipients. Similarly, we need to see what type of immune response the vaccine would elicit. So our institutional policy, getting a good comparison, is what we do for shingles. So for varicella vaccination, the older varicella immunization was a live attenuated vaccine that we told our transplant recipients they could not receive. The newer Shingrix vaccine was the brand name, which is not a live attenuated virus. We still don't allow our transplant recipients to receive because it results in a big T cell response. And our concern was that this T cell response overall might kind of elicit a larger kind of revving up of the host immune system that might precipitate a rejection as a side effect. So I think if we see something like that, we might be nervous still about giving our transplant recipients this vaccine, especially if the general population uptake is high enough that we might expect herd immunity to protect our patients. So I'd say it's a really, really excellent question, and something that we need to see what the vaccine looks like before we can answer kind of intelligently.
Okay, great. There is actually one just thought that it is come from one of our colleagues. He said it's completely correct to compare COVID. It is not completely correct to compare COVID-19 mortality between dialysis patient and transplant recipient, as far as there are a significant case mixed difference such as age on dialysis and comorbidities in dialysis as usually not suitable and rejected for transplant. So do you think we should wait more and not rely on this argument only, especially for living-related transplant?
Yes, I completely agree with that. And I'm glad he said that. It's a very important distinction when we talk about the ESRD data and dialysis that I told you about. So in that, I can tell you both in general and then in particular in that paper in the United States, the patients who are still on dialysis compared to transplant patients have higher age, have a higher prevalence of comorbidities. So in our ESRD network, patients have an average of almost 6 comorbidities. So things like heart failure, COPD, diabetes, hypertension, and advanced vascular disease that might preclude them from receiving a transplant. So for sure, these are not fair. You're completely correct. These are not fair comparisons. But if we just look overall, just as a clinical kind of gestalt about what we might expect, I think the point of that was just that there's no reason to believe that other groups have kind of any better outcomes than patients who have kidney transplants. And that we know pretty well from international data, especially from China, that chronic kidney disease itself and lower GFR had a kind of a dose-response relationship with more severe disease. So while I completely agree that dialysis mortality data should not be the deciding factor in determining when we should resume transplants, especially for living donor candidates, I think what we should keep in the back of our mind is that patients on dialysis will continue to have a high level of exposure because they have to leave home, they have to interact in a dialysis center that involves a lot of patients, and that their outcomes will still be generally poor probably overall. So we need to keep in mind that there is a risk of staying on dialysis, but I completely agree. I could not agree more that these are not fair comparison groups.
Yes, I agree with you also, because if we have experience from Spain and Italy, they started to resume their program, and they know that they have the patients have a chance of up to 26% in Spain to get COVID positive. In spite of that, they continue to continue with their living and disease program. And I am aware that also in the United States, they started to have to function in a full rate in some area, not in the United States. Another question, many questions actually come about the immunosuppression monitoring during COVID-19, how you are going to see the level of tacrolimus, or and how frequent you are going to do and monitor your patient when he's at home.
Right. So this has been a particular challenge early in the pandemic, when we still had many patients who were early out from transplant. So among those patients, at the first phase, so when we were first seeing that rise, we tried to continue our typical monitoring strategy of twice weekly labs. That's what we do for our brand new transplant, just to make sure that we're not getting subtherapeutic levels. As we've gotten further out from the main from the main time in which we paused our transplants, right now we have very few patients who are within 3 months of new transplantation. For those patients, I think it's somewhat provider dependent and dependent on how much their levels have fluctuated, but there's no one who, at least I'm getting labs on more than once a week. And for people who have stable levels on more than one draw, I'm trying my best not to have labs done any more frequently than once every 2 weeks. Because even for patients who have home visits for labs, there's some concern that the nurse who's coming to draw their labs is visiting other homes. So I'd say, unless there's a compelling reason to, my personal practice had been no greater than 2 weeks. Of course, once we resume transplants new again, I think we will not, if someone was within their first month or two, I would not feel comfortable probably waiting more than a week between draws, but I think we'll have to take that as it comes as a program reopens.
My personal questions to you: when you think that you will restart your transplantation program again from living donations?
I think probably this will occur somewhat based on how the city's phased reopening progresses. I think there's a couple factors. So one is logistics. So I think we'd want to make sure that our deceased donor program is up and running smoothly, just because we know that if the logistics for deceased donor kidney recipients are working well, then we know that this ethical obligation towards protecting living donors themselves, and this first doing no harm to living donors, that logistics of that will be simply to sort out as well. So I think one criteria will be that we want our deceased donor program to be up and running very smoothly. The second is, I think we want to see that New York is in an advanced phase of reopening, just to make sure that there's not widespread community transmission leading to a second peak, because this has been the big concern, is that as the city reopens, there's a large second peak of illness, and the hospital will become overwhelmed again. It will become a dangerous place for donors, and also there'll be a big shortage of equipment. So I think realistically, the earliest that will happen is probably at least 4 weeks from now, because we want to get it to advanced stage of the reopening and also see that that's been done safely. So I think the deceased donor program, though, is really opening up imminently. So we've started, we did a deceased donor transplant last week, actually. And we're continuing to, I think, right now, increase and ramp up our deceased donor program as the pandemic has started to fade away.
Okay. There are many, new drugs is coming out as a treatment of COVID-19, different protocol, different drug. How you are dealing with such a protocol of management with the immunosuppression? Probably you have to do more monitoring of the blood of the level, or you just give the same dose or reduce the dose?
So I won't go too much into this just because I don't want to steal Marcus's talk for Monday, because he's going to talk about this.
Okay, sorry for that.
I'll tell you a little bit, which is just that we don't know a lot about any good evidence about interactions that are significant for us, for outpatients, to change our monitoring behavior. And none of our outpatients are really receiving things like remdesivir, hydroxychloroquine, azithromycin. So from an outpatient perspective, that's not been an issue, and has not impacted our immunosuppressant monitoring. But I will leave the rest of the more complicated answer to Marcus for Monday.
The other questions, which probably from one of my colleague, he said that if you got now COVID positive donors, are you going to find the recipient for him? This is, I think we answered it before that. In many areas they started to take the COVID positive because it's not transmitted through the blood. But I want your opinion about this.
Right. So actually, I'll add something onto what I said last time. So I'd say overall, I think we would want, for deceased donor, we would not transplant that kidney based on our current practice. And for a living donor, we'd want them to be symptom-free for probably several weeks and testing negative on several tests for several weeks. But I think an added question about that is, and I think the reason that's especially true for kidneys, because we know there's ACE2 expression in kidney epithelial cells. So it's reasonable to believe that the kidney is a reservoir for transmissible disease. So unlike perhaps liver, for example, you might say that the liver could be safely transplanted because we don't believe it's being transmitted to the blood. For the kidney, we know it's been established in multiple studies that there is SARS-CoV-2 virus present in the kidney itself, in renal epithelial cells. So to me, it's clearly not safe that these patients with active disease could be used as donors. A second part of the question, though, is what if you have a donor who's antibody positive, who never experienced known disease, and who never tested positive? I think that as long as we take the same precautions, we'd have to assume that they need serial negative testing over several weeks. They could probably still be used. I don't think there's any role for something like a kidney pair donation, where we take an antibody positive donor and an antibody positive recipient, for example, to try to match them up, just because right now we don't totally understand what the protective impact of those antibodies are. So right now, I think our overall goal will be to make sure any donor is negative, is asymptomatic for a period of several weeks, and has serial negative testing and is asymptomatic before they are allowed to donate.
In your talk, you mentioned something about rejection and management of rejection if the patient is COVID positive. Someone asked again about this. If you just mention this again, please.
Sure. So right now, it's still pretty early, and I think we're going to see a lot more of this as patients recover from this period of having a high inflammatory state and reduced immunosuppression. But right now, we've only had one patient who had rejection, acute rejection. Actually, he was found to have asymptomatic COVID-19 on 2 tests. So he had confirmed COVID-19 that was diagnosed the same day as an acute cellular rejection, grade 2A. So obviously this patient needed some treatment of rejection because he had an aggressive rejection, but also had active COVID-19 disease. So our protocol for him, which was developed in conjunction with the head of transplant surgery, head of transplant nephrology, infectious disease, and discussion with pathology about the aggressiveness of his rejection, was that he initially was treated with just increased tacrolimus trough as well as IVIG and tocilizumab, with the thought that perhaps tocilizumab might blunt the immune response in the kidney until he get more definitive treatment. With that strategy, over a period of a couple of weeks, his COVID-19 testing turned negative, but his creatinine did not improve, and a repeat allograft biopsy showed ongoing high-grade rejection. So at that point, since he was asymptomatic and had serial negative testing, he was treated with thymoglobulin and high-dose steroid pulse, and he did fine from both a kidney perspective and from a respiratory perspective.
Dr. Hassan, really, we appreciate whatever you said today. It was very informative, very, very informative lecture, and we are happy to host you in Saudi Society. And just 1 minute, I want to close something to see you. Okay, so it was nice talk, nice answer, perfect answer actually. We learned a lot today, and we are happy to have you today. I would like at the end of this meeting to thank everyone who attend such an important talk and important discussion. And I appreciate again the work being done by the Saudi Society for kidney disease and transplant for nephrology and transplantation, and the executive committee, all of them, and as a head of them is Mitwalli and Hassan and Dr. Khalid, the dynamo of this society. And I would like to thank again Al-Hikmah for their supportive to such scientific meeting everywhere. And thanks for Dr. Bahir, Dr. Muhammad, and all from Al-Hikmah. Thank you very much, and have a nice night, and also be safe at home and at work.